Welcome everyone, and thank you for attending our October Mended Hearts meeting. My name is Karen Bertozzi. I am the Chapter 94 Secretary. I'd like to extend a warm welcome to anybody who's new to us and joining us for the first time. Just a quick little bit about Mended Hearts. We are an international organization that offers support to cardiac patients and their families. It's the largest cardiovascular support organization in the world. We visit hospitals, we visit patients over Zoom, and we even use an old-fashioned phone call to connect with patients as well. Our volunteers are passionate about providing support, education, and awareness to the cardiac community. We offer educational webinars and support. We have been serving the cardiac community in the Washington, D.C. area for over 48 years. So this organization has touched a lot of lives. I know it's played a big role in my life. The good news is membership is free. Just so you know, this session is being recorded. So you will be included in any of our social media. Mended Hearts does not provide official medical advice, right? So anything you hear tonight, take some notes and take it back to your physician. Tonight, we're going to learn about different cardiac medications. I know that when I was discharged after my open heart surgery almost 10 years ago, I walked out of there with 16 prescriptions. I know some of you can relate to that. So, and certainly in the past 10 years, my need for those medications have changed, right? And so I'm really looking forward to hearing what Rohini has to say. Rohini Choudhuri is our speaker tonight. She has a doctorate in pharmacy from the University of Maryland Baltimore campus. She's the Cardiology Clinical Pharmacist and PGY-1 Pharmacy Residency Program Director at Suburban Hospital. I hope I got that right. She's very passionate about providing comprehensive education about cardiac medications to her patients to help their overall outcomes. And in her free time, like all of us, she enjoys working out, reading, traveling, cooking, and spending time with family and friends. And so welcome. Welcome, Rohini.
Oh, thank you so much, Karen. Okay. So good afternoon, everyone. My name is Rohini, and as Karen said, I am the cardiology clinical pharmacist at Suburban Hospital. Today I'm going to be discussing cardiac medications. As we know, there's a lot of cardiac medications out on the market for various different types of cardiac disease states. For the purposes of this presentation, I'm only going to be focusing on medications as they pertain to hypertension, to atherosclerotic disease, which includes dyslipidemia and ischemic heart disease, and then heart failure. These three overarching disease states all kind of play a role together. Usually, if there's uncontrolled hypertension and uncontrolled atherosclerotic disease, it can increase someone's risk of having ischemic heart disease, like a heart attack, which down the line can increase a patient's risk for heart failure. So we'll go through these medications. There's going to be quite a bit of information during the presentation, but hopefully there'll be repetition so we can kind of understand each medication and their indication for these different disease states. So I'll go ahead and get started with hypertension. Hypertension is defined as high blood pressure, hyper meaning high, tension referencing to the pressure within our vessels. So that's where high blood pressure comes in with hypertension. Now, many of you might have a blood pressure cuff at home, and when you take your blood pressure, you usually will see two numbers that show up. That will be the top number, and then you have this fraction and a bottom number. The top number is known as the systolic blood pressure, or SBP. And what that number is measuring is the pressure in your vessels, and there's a pressure in your vessels, and then your heart is pumping against that pressure. So what it's measuring is the pressure that your heart is pumping against per beat. Now, the bottom number, which is known as the diastolic blood pressure, or the DBP, that is measuring the pressure within the vessels in between your heartbeats. So the systolic is looking at the pressure while your heart is pumping and beating. The diastolic is when your heart is at rest. So typically what happens here is your systolic blood pressures are going to read higher than your diastolic blood pressures because your diastolic blood pressures are measuring the pressure in the vessels when the heart is at rest. Okay. So Normally, the guidelines say that normal blood pressure is said to be a systolic blood pressure of less than 120 and a diastolic blood pressure of less than 80. If this is your blood pressure, continue to live that healthy lifestyle that you're doing. And typically, your blood pressure is checked during your annual visits with your primary care provider or your cardiologist. Now, when your systolic blood pressure starts to go up, so when it starts to hit between 120 to 129, but your diastolic blood pressures are still normal, that's when you start falling into the elevated blood pressure category. If you do fall into this category, typically we don't start patients on medications right away. We just really push on pharmacologic therapy. And what that is making those healthy lifestyle changes. So dietary changes, limiting your sodium intake, having adequate exercise, the 150 minutes of brisk walking or the 75 minutes of vigorous exercise, things like that. That's what you'd want to incorporate in. And then after that, you would go to the clinic in 3 to 6 months, and then your blood pressure would be reassessed. Now, if your systolic blood pressure is now starting to fall between 130 to 139, or your diastolic is falling between 80 to 89, now that's falling into a category known as stage 1 hypertension. Now, there's two subgroups within stage 1 hypertension, and that will dictate what the initial treatment algorithm will be. So if you have stage 1 hypertension based off these blood pressure readings, and you have a history of a cardiovascular event, so that would include things like a heart attack or a stroke, or if your calculated risk for a cardiovascular event in 10 years is 10% or greater, not only will we start pushing to make those lifestyle changes, but that's where medications start to come into play. So that's when all the antihypertensive medications are considered for treatment. Once you're started on the medication, then you'll come back to clinic within a month and get your blood pressure reassessed. Now, if you have stage 1 hypertension and you don't have a history of a heart attack or a stroke, and the calculated 10-year risk of you possibly having one of those is less than 10%, then we just stick with, again, lifestyle modifications, like I had discussed before. And then you'll come back into clinic 3 to 6 months afterwards for a reassessment on your blood pressure. Now, if your blood pressure is still uncontrolled, that's when medications start coming into play. All right, so the highest form of hypertension in the guidelines is known as stage 2 hypertension. This is when the systolic blood pressure reads 140 or higher, or the diastolic is reading 90 or higher. Here, again, lifestyle modifications are important. With whatever stage of hypertension or blood pressure readings you're in, lifestyle modifications are a mainstay. But then here also medications play a role, and that's really important, especially within stage 2 hypertension. Now, some patients in stage 2 hypertension actually will qualify to be started on 2 different antihypertensive agents from different medication classes right out the gate. So that'll be up to your provider's discretion. Typically, it's when your systolic is actually starting to read over 150 and your diastolic is reading over 90. Once you're started on the medications, your blood pressure will be reassessed within a month, and then medication adjustments will be made accordingly. So I just talked about what our overall treatment algorithm will be, but what type of blood pressure goal are we trying to reach? So the guidelines say that a blood pressure goal of 130 in your systolic and 80 in your diastolic is what we're trying to reach. However, it's important to know that each patient is different. Each one of us are different. So your provider might be telling you different goals based off your past medical history and your situation. So some patients might have a more lenient blood pressure goal of like 140 over 90. So it's really important to discuss those goals with your provider to see what's most appropriate for you. Okay, so I spoke about medications being initiated in patients with stage 1 hypertension who have a history of a cardiovascular event such as heart attack or stroke, or their risk of having one in the next 10 years is at least 10%. And then also we start those medications in patients with stage 2 hypertension. So what are those medications? I know I'm aware the slide is pretty overwhelming. There's a lot of information, but I'll break it down. I'm going to start with the first line agents. And first line agents are the ones that we go to and try to maximize on first before we start thinking of other agents. So thiazide diuretics fall within our first line agents. That includes hydrochlorothiazide and chlorthalidone. And the way this medication class are known as diuretics work is that they work in the kidneys and they actually stop the kidneys from absorbing too much sodium. And it's known that fluid and water follow sodium. So if we're inhibiting the kidneys from absorbing that sodium, so you're starting to release that sodium while you urinate, you're going to start urinating out more fluid and water as well. So then that'll reduce that blood pressure and that tension within the vessel. Now, as you're starting to, urinate out more sodium, your doctor is going to want to check some blood work on you. They want to make sure your sodium isn't starting to dip too low, along with some of the other electrolytes that I have listed here. Another thing of note is if you're a patient with gout, sometimes this can cause your uric acid levels to bump and you might start feeling the pains, gouty attacks. So if that happens, you might have a uric acid level checked on you as well. The next two drugs, the first one is known as an ACE inhibitor. The next one are known as angiotensin receptor blockers or ARBs. These two medications are cousin medications. They're related to each other very similarly in mechanism. ACE inhibitors, examples are lisinopril, enalapril, ramipril. There's more on the market. If you see a medication ending with the suffix pril, it's likely an ACE inhibitor. Examples of ARBs are losartan, valsartan, and olmesartan. Again, there's more on the market. If it's ending with sartan, it's likely an ARB. So these medications are working in relation to angiotensin 2. ACE inhibitors and stop the production of angiotensin 2, and ARBs actually stop angiotensin 2 from binding to its receptor. So what does that mean? Angiotensin 2 is a substance in our body that causes our vessels to constrict and shrink up. And so if it's constricting and shrinking up, the pressure starts to go up in that vessel. So when we stop the production of angiotensin 2, or we're stopping angiotensin 2 from binding to its receptor, now we're going to stop that constriction from happening and that vessel starts to relax and dilate and open up. So when it starts to dilate and open up, the blood pressure starts to go down. Now, with these medications, you want to monitor potassium. Patients may start seeing that they have high potassium. So again, your doctor will bring you back into the clinic to make sure your labs are okay for potassium and to make sure your renal function is stable. Usually these medications are great for stabilizing renal function. Sometimes they do a little too good of a job of that. So we want to make sure your renal function is staying stable and not starting to decline. ACE inhibitors specifically are also known for a few special side effects. One of them is cough, and which is bothersome to patients. It's not an allergy, but it's bothersome. Another one, which is rare, is known as angioedema. Angioedema is swelling of the lips, the throat, the face. It can cause respiratory issues, breathing issues. So while for a cough it's bothersome and you can just call your cardiologist and ask to be switched to another medication, typically that would be an ARB. When it's angioedema, you want to come to the hospital because that has to be treated right away. But that is specifically for ACE inhibitors. This is not as true for ARBs. If you were to ever have an angioedema event with an ARB, it would not be it wouldn't be because it happened with an ACE. It would usually be through a different pathway altogether. So typically, if you have a cough with an ACE, we switch those patients to ARBs. If you have angioedema with an ACE inhibitor, you could be considered to be put on an ARB, but usually we need a washout period to make sure that we're not rocking the boat too much. ACEs and ARBs, as you can see, they work very similarly, but using them together doesn't make them stronger. So a lot of studies have looked at using ACEs and ARBs together, and they found that it didn't give patients more benefit. It actually created more side effects like high potassium and stressing the kidneys out too much. So we don't use these medications together. And we don't use them in pregnancy. The other first-line agents include calcium channel blockers. There's two different types. There's dihydropyridines, known as DHPs, and non-dihydropyridines, known as non-DHPs. Our DHP calcium channel blocker examples are amlodipine and nifedipine. Non-DHP calcium channel blocker examples are diltiazem and verapamil. Now, overall, all calcium channel blockers work by inhibiting calcium from entering a certain channel known as the L-type channel. And what that does by inhibiting calcium entrance is it allows a vascular smooth muscle to relax as a cardiac muscle. So if you're relaxing the vascular smooth muscle of your vessel, that vessel is going to start relaxing and opening up again. And that's how your blood pressure starts to go down. Now, our non-DHP calcium channel blockers like diltiazem and verapamil, they work a little bit more on the heart. So you actually might start seeing a side effect of slowing the heart rate down. So lower heart rates come as a side effect with non-DHP calcium channel blockers. Overall, these calcium channel blockers, we don't like to use them in patients with heart failure with reduced ejection fraction, with the exception of amlodipine. That's because it can cause a heart failure exacerbation. Sometimes it can worsen outcomes. So we don't really use these medications in those patients. Patients who are on higher doses of these medications can sometimes see swelling of the ankles and the feet, known as pedal edema. Doesn't happen to everybody, but something to look out for. And like I said before, non-DHP calcium channel blockers can lower the heart rate. Okay, so now I'm going to go into our second line agents. And first up are our loop diuretics. Examples are furosemide, bumetanide, and torsemide. These work similarly to our thiazide diuretics, just in a different part of the kidney. But essentially what they're doing is stopping that reabsorption of the sodium like I was talking about. And water and fluid follow sodium. So then you're going to start urinating out that extra fluid and water as well, which will allow your blood pressure to go down. Similarly to the thiazide diuretics, you likely will have a panel done to make sure your sodium and other electrolytes are not going too low. When you're at home, we like to tell patients to check their blood pressure while they're on these medications known as diuretics. That's because you're urinating out that extra fluid, which can sometimes lead to a lower volume status in the body. And so if your blood pressure starts to go too low, that probably means you're losing too much volume in your body. And sometimes your kidneys can take a little bit of a hit because of that. Another side effect, which is a little bit more rare with loop diuretics, is ear ringing or tinnitus. Some patients might complain of that. Usually, if you stop the medication, the ear ringing goes away. Next medications are mineralocorticoid receptor antagonists. I'm going to refer to them as MRAs for the rest of the presentation. Examples are spironolactone and eplerenone. The way these medications work, so they work in the kidneys and the heart, and they block this substance known as aldosterone from binding to a receptor known as a mineralocorticoid receptor. Downstream effects, it slows down inflammation and fibrosis in the kidneys and in the heart, but it also works in the kidneys to allow for release of sodium, which again will allow for release of the extra fluid and volume. But it also will allow your body to hold on to potassium. So again, you will be called into the clinic to get labs done to make sure your potassium isn't too high, because you will be holding on to potassium, and to make sure your sodium's not too low. Again, similar to the loop diuretics, checking for volume status and renal function. And then spironolactone over eplerenone has this side effect called gynecomastia. Gynecomastia is known as the development of breast tissue or swelling of breast tissue. And this is more common with spironolactone rather than eplerenone, and this can be especially concerning to male patients and bothersome. So if you do experience this, you can go back to your doctor, and typically what will happen is they'll switch you to eplerenone since that risk is less. It's not zero, but it's less. Also, if you're a patient with a history of heart failure with reduced ejection fraction, the use of these MRAs would not be second line anymore. They eventually will become first line for you. Okay, the next one are beta blockers. Examples are metoprolol, carvedilol, and bisoprolol. There's a lot of them on the market. They're ending with LOL, then it's likely a beta blocker. Beta blockers block a receptor on the heart known as the beta-1 receptor. And as they block the beta-1 receptors on the heart, they actually slow the heart rate down. Some beta blockers also are a little bit more non-selective, which means they're hitting your beta-1 receptors on the heart, and they're also hitting another receptor known as beta-2 receptors. Those receptors are found on your lungs, your two lungs, beta-2, two lungs, beta-1, one heart. If you are a patient with a history of asthma or COPD, we typically do not put patients on these non-selective beta blockers that hit the beta 2 receptors because it can kick up your asthma and COPD. There's other beta blockers that hit your beta 1 receptors and alpha receptors that are on your vessels. And as you block the alpha receptors, your vessels will vasodilate, blood pressure starts to go down. So an example of that would be carvedilol. I just talked about our important pearls that, all these will lower your heart rate and not to use a non-selective beta blockers in reactive airway disease. Another important thing is that you don't want to suddenly stop your beta blocker yourself at home. If you've been on a beta blocker for a good amount of time, your body gets used to it. So if you stop it, cold turkey, your heart rate's going to start shooting up, blood pressure will start shooting up, and those are things that we don't want. So if you have a need to get off the beta blocker, it's important to talk to your doctor to do that. Beta blockers are known to make patients not feel great when they first start them, but usually those side effects are self-limiting. That includes like feeling really tired, just really icky overall, dizziness. Sometimes some patients will complain about. Some of these beta blockers are taken once a day. Usually we tell the patient, go ahead and take it at night and it will resolve the symptoms as well. And again, beta blockers will become eventually first-line agents for you if you have ischemic heart disease or if you have heart failure. Now, the final second-line agent are direct vasodilators known as hydralazine and minoxidil. These medications work directly on your arteries and they relax your arterial smooth muscles. And if you relax your arterial smooth muscles, they start to vasodilate and get bigger. So if they get bigger, you get a decrease in your blood pressure. Now, one of the odd side effects with these medications is they can cause actually retention and holding on to sodium in water. Typically, it'll cause like your legs to swell up. It's not really going to cause your blood pressure to go up. So many patients who are on things like hydralazine might also be on a diuretic, like a loop diuretic or a thiazide diuretic, like we talked about. Also, as you cause the arteries to open up directly and cause your blood pressure to go down, your heart will start to react to that. It'll start to compensate for that blood pressure suddenly going down. What usually happens is your blood pressure suddenly goes down, your heart rate starts to go up a little bit. So these medications can actually cause your heart rate to go up. So many patients who are on these medications, if they have that side effect, they might be started on something like a beta blocker to bring the heart rate down. And then with really high doses of hydralazine, sometimes some patients can experience hydralazine-induced lupus-like syndrome. So you'll have like a lupus-like presentation, but it's induced by high doses of hydralazine. Usually this resolves if you're taken off the hydralazine, but this is a very rare side effect and it's with really high doses. So I wouldn't take this as a catch-all in regards to hydralazine. Okay, so that was a lot of information with hypertension. A lot of those medications will come back around in this presentation, so we'll see them again. I'm next going to go on to atherosclerotic disease and specifically focus on dyslipidemia, which is known as a disturbance or an elevation in some part of the lipid panel or profile. Our lipid panel or profile is made up of 4 components: total cholesterol, LDL, which is known as our bad cholesterol, HDL, which is known as our good cholesterol, and triglycerides. Overall, we want to make sure our total cholesterol, LDL, and triglycerides aren't too high. And HDL is cardioprotective. It is good for the heart. We want to make sure that's high. So I have the values here. For the purposes of this presentation, I'm going to be focusing on LDL. So overall, if you're a patient who has not had a cardiac event, we usually focus on keeping your LDL below 100. Now, if you're a patient who has a cardiac event history or high risk of cardiac event history, but specifically a cardiac event history, we want that LDL to be below 70. And that's because LDL is directly related to increased risk of a cardiovascular event, meaning a heart attack or a stroke. Okay, so I have a little drawing here. So here I have an artery, really any vessel that you think of. If you see this space here, this space we want to keep nice, big, and round because you got blood flow going through this space of the artery, this opening of the artery. You always want to make sure that you have good blood flow through your artery or vessel because blood carries oxygen. And that oxygen is going to come perfuse other organs, and it's also going to perfuse back into the heart. So good blood flow means good oxygen, and we're going to bring that good amount of oxygen to the heart and to the rest of the body and the organs. Now, when someone has high LDL levels, that LDL starts to deposit into this area of the vessel. So as one can imagine, when I start depositing LDL and plaque into this area of the vessel, this, what we call the lumen of the vessel, starts to become smaller. So if I have a smaller area in this vessel, I have less blood flow going through and I have less oxygen getting to my organs. I have less oxygen getting to my heart. And that's an issue. So it's really important to keep those LDL levels under control. Now, if you're a patient who does not have a history of a cardiac event, but you could be at risk, this algorithm is for you. So I'm going to focus on ages 40 to 75. If your LDL is between 70 to 190, we start calculating your risk of having a cardiovascular event. And that risk can go from low risk, which you can see here is less than 5%, all the way up to a high risk, which is at least 20%. And I'm not going to go line by line here, but if you're a low risk for a cardiovascular event, we usually just emphasize lifestyle changes and living a healthy lifestyle. As you start going down this line, you start seeing statins starting to make an appearance here. If you're borderline risk, you can consider a moderate intensity statin. I'll touch on what that means in a second. If you're intermediate risk, we definitely want you on a moderate intensity statin. And if you're at high risk for a cardiovascular event and you haven't had one yet, we really want you to take a high intensity statin because we need to bring those LDL levels down. So it's not depositing into the vessel and making it hard for maximal blood flow and oxygen to get to your heart and your organs. Now, I want to bring your attention to this side of the chart as well. If you are a patient with an LDL of 190 or over, we don't start calculating your risk of having a cardiovascular event. You're put straight onto a high intensity statin. Now, if you're a patient with a history of diabetes and your age is between 40 to 75, all of these patients would be started on a moderate intensity statin. But if you're further worked up by your doctor and they think your risk of having a cardiovascular event is even higher, they might bump your intensity of the statin up to a high intensity statin. So now the question is, okay, well, you may be a patient who had a cardiovascular event. You might have had a heart attack or a stroke in the past. So what does that mean for taking care of your LDL levels and what treatment is there? So if you had a cardiovascular event, but you're not at high risk or very high risk for another one, and your age is 75 or less, we recommend you continue a high intensity statin if you've been started on one, which typically we like to have patients on these. Now, if you're unable to tolerate a high intensity statin, then we start taking you down to a moderate intensity statin. All that to say that we want to make sure your LDL levels go below 70. So if they're not going below 70 after being on your maximally tolerated statin, we start adding other agents on. An example of that would be Zetia. Now, if your age is over 75, it's a risk versus benefit of if you're on a moderate or high intensity statin. But if you've been on a high intensity statin and you tolerate it, then we just recommend to continue it. Now, if you had a history of a cardiovascular event, but you're also very high risk for having another one, all patients would be on a high intensity statin or maximally tolerated statin, and that's based off side effects. Now, if your maximally tolerated statin is not bringing your LDLs below 70, then we start adding on other agents. An example, again, Zetia. Now, if Zetia with their statin isn't doing the trick, then we start thinking of injectable agents. An example would be a PCSK9 inhibitor. Okay, so let's get into the actual medications. So first-line agents, as you can probably tell through the algorithms, are statins. So I have a whole bunch of statins listed here. I'm really going to focus on what intensity means in terms of statins, and then I'm going to focus on atorvastatin, known as Lipitor, and rosuvastatin, known as Crestor, since those are our true workhorses within the statin group. So high-intensity statin means I want to drive your LDLs down by at least 50% or more. And this is really beneficial for patients who are high risk for a cardiovascular event or already had a cardiovascular event. Also keep in mind statins reduce inflammation in your vessel, so that's an added benefit with using them. Moderate intensity statins reduce your LDL by 30 to 49%, and low intensity reduces it less than 30%. So again, if you're high risk, we really want to try and stick with our moderate intensity statins. The only moderate intensity statins we can use here are atorvastatin, 40 to 80 milligrams, or rosuvastatin, 20 to 40 milligrams. Now, how do statins work? They work on an enzyme known as the HMG-CoA reductase enzyme, and it's usually found in the muscle. It inhibits this enzyme, and because it inhibits this enzyme, the downstream effect is it stops making cholesterol, and you don't make LDL, or you reduce your LDL production, which is what we want, right? We're trying to reduce our LDL here. Another downstream effect, and I want to explain this because some other medications work similarly to this, is statins downstream can also upregulate what we call the LDL receptor. The function of the LDL receptor on your cell is to catch the LDL that's swimming in your blood and then eat it up. So if it's catching the LDL and eating it up, we're starting to clear your blood of LDL, and that's what we want. So it upregulating the LDL receptor is exactly what we want as well. Because it's working in the muscle, patients may complain of muscle pain. Now, there's a whole gradation of what muscle pain means. There's muscle pain, and then you go all the way up to muscle breakdown. Muscle breakdown is rare. Muscle pain can happen when you start a statin. Usually it's self-limiting. We really try to tell patients, please do not self-discontinue statins. Usually they go away. It's important to call your doctor. If you're having those pains, what they may do is have you hold your statin for a certain amount of days, and then have you restart the statin at a lower dose, or they might have you restart a statin, just a different one. So if you're having muscle pain, please talk to your doctor before trying to have a game plan. Just don't stop the statins because there's a lot of benefits with these medications. Statins interact with grapefruit. So if you're a huge grapefruit fan, I like to recommend patients to dial back on that. They like to increase the level of statin in your body. And so if you weren't having muscle pains before, you might start having muscle pains now. So grapefruit we like to steer clear from. And very rare, but statins could sometimes put a little pressure on the liver. So your doctor might be checking your liver enzymes to make sure those are stable. But again, very rare to see any type of liver disturbances with statin use. I have yet to see something that's only from statin use. So that's really rare. Now, the question is, if you need to be added on something with your statin because your LDL levels are not going down, or if you're really deemed to be statin intolerant, what are other medications out there? Now, for the purposes of this presentation, I'm just going to be focusing on oral medications. The last two medications in green here are injectable agents. If you have questions about them, I'm happy to answer them at the end of this presentation, but I'm really going to be focusing on ezetimibe, known as Zetia, or bempedoic acid. So ezetimibe works on a certain transporter at the brush border of your small intestine. And what it does is it stops this transporter from reabsorbing cholesterol into the body. So you don't reabsorb cholesterol into the body, your LDL levels start to go down. Some patients may complain of muscle pain or soreness. And we like to check liver enzymes in patients as appropriate, especially patients who are on Zetia with a statin. And then our last oral agent here is known as bempedoic acid. It works on an enzyme known as ACL. The ACL enzyme works in the same pathway as the HMG-CoA reductase enzyme, which is what the statins inhibit. So it inhibits the ACL enzyme. And again, since it's working in that same pathway, it stops the production of cholesterol. And like the statins, it also increases your LDL receptor. So now you have more receptors to catch and eat up that LDL and clear it out of the blood. Bempedoic acid has been seen to increase uric acid levels, so we typically don't recommend its use in gout patients. We check renal function and liver function tests as appropriate in patients as well. There is a very rare risk of tendon rupture. And because it is a newer medication, it is more on the expensive side, but there are coupons out there. Okay, so I just spoke a whole lot about medications to reduce LDL, and that's because as LDL, builds up, we start building up plaque in the vessel. Now, sometimes that plaque is stable and it just keeps building up in the vessel. It's still not something we want because we're still reducing blood flow and oxygen flow to your organs and to your heart. Now, sometimes that plaque can become unstable and it breaks off. We call that plaque rupture. And when that plaque breaks off or it ruptures, it causes a downstream effect of platelets now coming to that site where that plaque ruptured. It's almost like the body thinks that's an injury that happened to the vessel. Now, when you have platelets now coming to that area, you start forming a clot. So now we thought we had a smaller area for the blood to go through. Now we have a very small area for the blood to go through because now we have this massive clot going in our vessel. And so when you start going down this area of a clot forming, that's when you start going into the area of possibly going and having a heart attack. So I'm going to touch on that a little bit in a second. So, like I said, when you have your vessel and now you have this LDL starting to come into play, that vessel, the area in which the blood can go through is starting to go down. So when you have reduced blood flow, you have reduced oxygen supply. And so you have reduced oxygen supply back to the heart as well. And the heart has oxygen demands that it needs to be met. But if I have reduced blood flow and reduced coronary blood flow in my heart, I'm bringing less oxygen to the heart and I'm not meeting the cardiac oxygen demands that my heart needs. So that's the problem. And we need to be able to balance that out for patients that are, starting to fall into this ischemic heart disease picture. So there's two types of ischemic heart disease. The first one is stable ischemic heart disease. So that is where I said the plaque in the vessel has not ruptured. It is stable, it's building up, but it hasn't ruptured. So right now, we haven't caused platelets to come and start sticking together to create a clot. Now, if that plaque does become unstable and it does rupture, that's when your platelets are going to start thinking that they got to stick together and fix that area. And now you have this big clot forming. And we thought you had a small area in that vessel for the blood to go through. Now it's even smaller. So this is where patients are at high risk for a heart attack or already having a heart attack. Okay, so number one thing for ischemic heart disease, statins are very, very important. But what else is important here? Like I said, some of these patients are starting to have plaque rupture and platelets forming to create a clot. So this is where antiplatelet agents come into play. The first one that many of us know is aspirin. It irreversibly inhibits what we call our COX enzymes. And so when it inhibits these enzymes, it actually reduces the production of prostaglandin and thromboxane A2. These two substances are they help with platelets sticking together. So if we're reducing the production of prostaglandin and thromboxane A2, the platelets are not going to be sticking together, which is what we want. Now, because platelets are not sticking together, you have to monitor for signs and symptoms of bleeding. So that would be looking for bruising, unprovoked nosebleeds, gum bleeds, but also your doctor will probably bring you in as well to check your blood counts and see if your hemoglobin is drifting down or if it's stable. Aspirin is also known to be kind of hard on the stomach. So, if you have acid reflux, it can kick that up. Really, like, worse things could be ulcerations. Again, not everyone on aspirin is having ulcers form, but patients can complain of like gas and acid reflux. I usually like to tell patients that for daily aspirin use, like a baby aspirin 81 milligrams, you can use an enteric coated form of the tablet that usually kind of saves your GI tract. Now, if you are a patient who is, in the onset of having a heart attack or an acute coronary syndrome, that's where chewable aspirins are needed. Usually you will hear EMS or a doctor tell you take 2 to 4 chewable baby aspirin tablets if you're starting to have chest pain and a possible heart attack. So that's where you want to use the chewable baby aspirins, not the enteric coated ones. Other than that, enteric coated ones will be good on the stomach. And then again, it is a blood thinner. So if you're about to have any procedures, let your provider know that you're on this medication to see if you need to hold it before a procedure. The second antiplatelet agents that we consider are P2Y12 inhibitors. Those are clopidogrel, ticagrelor, and prasugrel. Your platelets have this receptor known as a P2Y12 receptor, and there's a substance known as ADP that binds to the P2Y12 receptor usually, and that causes platelets to stick together and create a clot. These clopidogrel, ticagrelor, and prasugrel bind to that receptor and basically stop ADP from binding to it, so the platelets don't stick together. Clopidogrel and prasugrel bind to that receptor irreversibly, which means they don't pop off. Ticagrelor binds reversibly, so it can pop off. And I'll discuss in a second why that's important to think about. Now, again, these are blood thinning agents, so we got to look out for signs and symptoms of bleeding, and your doctor might be checking your hemoglobin and your platelets on your labs. Ticagrelor has a very interesting side effect, not common, but it can happen. Some patients complain of shortness of breath. Other patients start getting slow heart rates or like a slow heart rhythm. Clopidogrel, so this is actually a drug interaction I want everyone to pay attention to because it's with the over-the-counter drug. Clopidogrel interacts with Prilosec or omeprazole. It also interacts with Nexium. Prilosec or Nexium actually reduce the efficacy of clopidogrel, which is not what we want in an ischemic heart disease patient. So if you are having acid reflux, please talk to your doctor. You could consider other medications like Protonix or Pepcid, but we really discourage the use of clopidogrel with Prilosec, which is omeprazole or Nexium. These P2Y12 inhibitors are used with aspirin typically in post-acute coronary syndrome patients, so post-heart attack patients. That's known as dual antiplatelet therapy, and it's usually done for about a year. And you want to let your provider know, again, if you're about to get any invasive procedures, especially surgery, that you're on one of these medications. So this is where the binding plays a role. Clopidogrel and prasugrel, like I said, irreversibly block that receptor on your platelet. So if you're about to go for surgery, you're going to have to hold your clopidogrel and prasugrel longer than if you were on ticagrelor, because ticagrelor gets out of the system a little bit quicker because it has reversible binding and blocking on your P2Y12 receptor on the platelet. Okay, so now you're going to start seeing some repetition of the drugs that we just talked about. Beta blockers are used in ischemic heart disease. And what they actually do is that they help reduce the cardiac oxygen demand. So how is it doing that? As we know, beta blockers work on our beta-1 receptors on the heart, and that leads to a slower heart rate. So a slower heart rate will actually reduce the cardiac oxygen demand of the heart. So if your vessel has having reduced blood flow and cardiac oxygen supply, at least we're starting to drive down that demand so we can balance it out a little bit. Beta blockers are also used after heart attacks or any other acute coronary syndrome events for possible reduction in cardiovascular mortality and reduction in cardiac remodeling. Now, our calcium channel blockers are starting to make a appearance here too. Now, our non-DHP calcium channel blockers, which are diltiazem and verapamil, and remember, those are the ones that work more on the heart. They, like I said, slow your heart rate down, just like the beta blockers do. So in stable ischemic heart disease, the slower heart rate will reduce that cardiac oxygen demand. Now, your DHP calcium channel blockers, such as amlodipine and nifedipine, are, relaxing that vascular smooth muscle so it can open up a little bit more. And so what it's doing is it's actually opening up those coronary vessels and allowing for more blood to start flowing through. So I have more blood flowing through, I have more oxygen flowing through, and so I'm increasing my cardiac oxygen supply. And then we have ranolazine. Ranolazine inhibits a certain sodium channel on the heart, and that downstream reduces the influx of calcium. What does that mean? In the heart, when that happens, you have your heart, the ventricle part of the heart has the wall, and that wall sometimes can get really tense. So if we go down this mechanism of action, it actually relaxes that ventricle wall so it's not as tense. So if I'm relaxing my ventricle wall of the heart and it's not as tense or stressed out, I'm reducing the cardiac oxygen demand of my heart in stable ischemic heart disease. Your doctor may also do EKGs on you at intervals to make sure this thing called a QTC is not starting to widen. Usually when your QTC becomes prolonged or too long, it can lead to other cardiac disturbances. So they'll be watching that closely, but it's dose dependent and it's not very common. So nothing to really worry about there. Your doctor will be watching closely. And like statins, ranolazine interacts with grapefruit. So Again, we like to discourage the use of grapefruit, ranolazine. Its dosing is limited then if you're taking too much grapefruit. Nitrates are notorious for use in ischemic heart disease. That includes nitroglycerin, isosorbide mononitrate, isosorbide dinitrate. Nitroglycerin is usually converted to nitric oxide, and the nitric oxide starts to activate certain enzymes down the line, which start to work on vascular smooth muscle so it can relax your vessels. So then your vessels start to dilate and become bigger. And kind of similar to the DHP calcium channel blockers, when you got the bigger vessel, you got more blood flow going through it and more oxygen going through it. And so now your cardiac oxygen supply is increasing. If someone's having acute coronary syndrome like a heart attack, our translingual and sublingual nitrates are used for chest pain relief. Please keep in mind, if you're using this for chest pain relief in this setting, if you take one dose and your chest pain does not resolve in 5 minutes, please call 911 before taking that second dose. We want to minimize that time before you get to the hospital. Also, if you're a patient who's on medications such as sildenafil, tadalafil, or vardenafil, and you took that within 24 to 48 hours prior, you cannot take a nitrate because it's going to plummet your blood pressure. You don't want that. Things to look out for with nitrates, main things are headache and flushing. Many patients will complain about that. What we like to tell patients is if you're having a headache and you're having some flushing, that means it's doing what it needs to do. So it's not comfortable, but it's doing what it needs to do, especially if you're using it when you're having chest pain in the setting of a heart attack. And certain forms of this medication need a nitrate-free period, which means that you just have a period of time throughout a 24-hour period where you're not taking the nitrate medication. That's usually 10 to 14 hours. So you'll be taking it throughout the day, and then at night when you're sleeping for X amount of time, you're not taking the nitrate. Make sure it's about 10 to 14 hours of no nitrate use, because if you use it too often, sometimes it's not as effective. All right, so lastly, we have ACE inhibitors and ARBs. Now, these medications are not for all ischemic heart disease patients. We really only use it for high-risk patients who are post-acute coronary syndrome. So what are those high-risk patients? Those are patients who have an anterior heart attack. It's just a location where your heart attack is. Your doctor would know about that and let you know if that matters. If you have an ejection fraction of 40% or less, if you have hypertension, diabetes, or stable chronic kidney disease. Now, if you do fall into this list of things, usually we try to use an ACE inhibitor first, but if you can't use an ACE inhibitor for reasons like a cough or angioedema, then we might put you on an ARB instead. Okay, so that's atherosclerotic disease. Like I said, uncontrolled hypertension, uncontrolled atherosclerotic disease can put a lot of stress on the heart and sometimes lead to heart failure. So that's the next thing we're going to talk about here. So what is heart failure? To understand heart failure, we got to understand ejection fraction. So I'm going to first define that. Ejection fraction measures the percentage of blood that is being pumped out of the left ventricle of the heart with each heartbeat. And typically a normal ejection fraction is about 50 to 70%. So here I have an illustration of the heart, and I have all the chambers labeled here. The main chamber I'm going to focus on is the left ventricle. I do want to bring in the left atrium here because just to understand the blood flow here, your blood usually comes out of the lungs after it gets oxygenated. It goes into the left atrium, and then the blood dumps into the left ventricle. Usually then the blood will get pumped out of the left ventricle into your aorta, and then that'll pump to the arteries to your organs. So that's the function of the left ventricle. Here you can see the left ventricle has a good muscle tone. It's strong. It can pump that blood that's coming in from the left atrium, and someone with a good ejection fraction would pump about 50 to 70% of the blood that poured into the left ventricle out through the aorta to the organs. Now, like I said, there's different types of heart failure. I'm focusing on heart failure with reduced ejection fraction, which is an ejection fraction of 40% or less. And then heart failure with preserved ejection fraction, which is an ejection fraction of at least 50%. Now, in patients who have a reduced ejection fraction, and this can be in patients who are like post heart attack, these patients experience something called cardiac remodeling, and that is an all-encompassing term. But sometimes when patients have a heart attack, you have tissue death on the heart, and then the heart starts to remodel. And what that sometimes can cause is this left ventricle wall is starting to thin out now. Your left ventricle is getting bigger, but the wall is starting to thin out. That muscle wall is starting to become weak. So what happens is your left atrium is able to dump the blood and the fluid into the left ventricle, but now because this muscle is so weak, it can't forcefully pump out a good percentage of the blood that dumped into here out into the aorta. So now that's why you're starting to see your ejection fraction drop. It's only as strong as it can be, and it's only going to pump out a certain fraction of the blood that came in here because it's not as strong to pump out anymore. So in heart failure with reduced ejection fraction, we say that it's a pumping defect. Now, in patients with preserved ejection fraction, typically this left ventricle now has become very small, and that's because the wall of the left ventricle has become very thick and stiff. So when you have less space in the left ventricle, all the blood that was in the left atria, that blood, not all of it can now pour into the left ventricle because there's not much space in here. It's like taking a cup and making it smaller. So that small cup can't take the same amount of blood that that big cup was able to take. So here, your heart is able to pump out a good percentage of the blood that actually dumped into the left ventricle. But the problem is the left ventricle is not taking all the blood from the chamber above. So what does that mean? It's not taking enough blood. So now all this fluid and blood is starting to back up into the left atria. It's starting to back up into your lungs. It's starting to back up into the right heart. And so many of these patients start having volume overload, issues with breathing. They need pillows to, sleep upright. Your legs are starting to swell because your blood is not moving forward. It's starting to move backwards. But your heart is able to pump out a good percentage. It's just that there's not much blood dumping into the left ventricle. So that is known as a filling defect because it's not filling well from the atria into the ventricle because there's just not enough space. Okay, so I'm going to start with heart failure with reduced ejection fraction first, which is the pumping defect. Now, there is a four pillars of medications that we use that all heart failure with reduced ejection fraction patients, we aim to get them on. And it's because they reduce the risk of cardiovascular mortality. Yes? Okay. It reduces the risk of cardiovascular mortality and cardiovascular morbidity, which in this setting means a reduction in heart failure hospitalizations. The first one here are beta blockers. The guideline-directed beta blockers they recommend here are metoprolol succinate, carvedilol, or bisoprolol. So we usually don't go just to any beta blockers. Those are the three that we consider. What these do, like I said, they provide reduction in cardiovascular mortality and a reduction in cardiovascular morbidity. And it works against that cardiac remodeling. And, typically when you have injury to the heart is going to try and remodel. So it tries to work against that. So we can stop your ejection fraction from dropping too much further. And sometimes some patients actually see their ejection fraction get better. So beta blockers are very important here. Now, the second pillar includes the use of an ACE inhibitor or an ARB or another medication that I did not talk about yet, which is an ARB with a neprilysin inhibitor. We call that for short an ARNI, and the only example here is Entresto, which is sacubitril and valsartan. You have valsartan, which we know how it works. Sacubitril also induces vasodilation, so it's opening up those vessels, and natriuresis, which means that you're releasing sodium. So you're releasing any extra fluid that's not being cleared because of the heart. Now, these are all three cousin medications, so you'd only be on one of them. All of them, reduce cardiovascular mortality and morbidity. They work against cardiac remodeling, two things that we're really looking for. Now, the guidelines and the literature actually recommend the use of Entresto over an ARB or an ACE inhibitor, and that's because it conferred more reduction in cardiovascular mortality and morbidity in patients. But some patients, we got to work them up slowly to Entresto because it can be, it's very potent on the blood pressure. It can bring your blood pressure down maybe a little too well. Now, if you're a patient who is specifically on an ACE inhibitor and your cardiologist has told you, I want to switch you to Entresto, Keep in mind that you need to separate the two by 36 hours. So you need a 36-hour washout period. That's because ACE inhibitors and Entresto can sometimes cause buildup of a certain substance in your body, both of which can lead to cough and angioedema. So we want to make sure we wash all that out so we don't increase the risk of side effects. While Entresto is a great medication, it is a newer medication and it is more expensive. So something to keep in mind, but there are cost helping coupons out there. Now, SGLT2 inhibitors is a third pillar in this four-pillar approach. The two that could be considered here are empagliflozin or dapagliflozin. Anything ending with gliflozin likely is an SGLT2 inhibitor. And the way it works is it reduces glucose reabsorption, but it also reduces sodium reabsorption in the kidneys. Now, I want to be clear, just because it's reducing glucose reabsorption in the kidneys does not mean your blood sugar is going to plummet. They did a lot of studies of these medications in heart failure patients who did not have diabetes, and they tolerated the medication fine. Now, the SGLT2 inhibitors have also been shown to reduce cardiovascular mortality and morbidity in these heart failure patients. It can reduce, it is allowing your body to release sodium. So like I kind of talked about with our loop diuretics, our MRAs, and our thiazide diuretics, it might reduce your volume status. It's good. It's kidney protective, but as you reduce your volume status, your kidney might take a little bit of a hit first, and then usually it improves. Because you are urinating glucose, there could be a chance of a UTI developing or a yeast infection. So look out for signs and symptoms of pain on urination, frequency of urination, pain in your lower back, itching, things like that. Does it happen to everybody? Absolutely not. Just a side effect to look out for. And these are medications as well. We have to consider cost, but we like to set up patients with coupons as we can. Finally, MRAs is pillar number 4 in the 4-pillar approach. And these also reduce mortality and morbidity. And I want to be clear that the only MRAs that are used in these patients are spironolactone and eplerenone. And that'll be clear when I get into the next slide. But they reduce mortality, cardiovascular mortality and morbidity in these patients. And they work against cardiac remodeling by specifically reducing fibrosis and inflammation in the kidneys and the heart, as I alluded to back when we were talking about hypertension.
Excuse me, Rohini.
Yes.
There's some questions about what exactly you mean by reducing mortality and morbidity. Can you
So when I'm talking about reduction in cardiovascular mortality, that's like any type of cardiac related death. So it could be heart failure that has decompensated. By decompensation, meaning you have to come into the hospital and that has led to a death, or sudden cardiac death, or that leading to like an ischemic event, like a heart attack, things like that. That's what I mean by reduction in cardiovascular mortality, death that has been caused by a heart event. When I talk about reduction in morbidity, I'm specifically focusing on a reduction in heart failure based hospitalizations. Something that your hospitalization is because your heart failure has acted up. You can't breathe well. You needed more diet, like furosemide, to get rid of the fluid. Or your ejection fraction has dropped and now your blood is not going to the organs the way it should, and you need to be hospitalized. That's what I'm talking about when it comes to morbidity. I hope that clears that up.
Thank you.
Yep. Okay, so the next one is, so this is the last slide. This is focusing on heart failure with preserved ejection fraction and the medications that we use here. Now, I'm going to start using the word morbidity here again, and it's specifically focusing on hospitalizations due to heart failure. Now, first-line agents in this type of heart failure are loop diuretics, which is furosemide, bumetanide, and torsemide. And this helps the body get rid of that extra fluid because it's backing up like I talked about. So it gets rid of that extra fluid, so now your blood can start flowing forward a little bit more. Just a side note, we do use loop diuretics in reduced ejection fraction patients as well. But again, there's no mortality benefit. It's just reduction in heart failure hospitalizations. Now, second and third line agents. So our second line agents are SGLT2 inhibitors. And there's been a lot of studies showing how well it has reduced patients' hospitalization for heart failure in the setting of a preserved ejection fraction. So that's a reduction in mortality. It's a little bit more gray if it actually reduces cardiovascular death or cardiovascular mortality, but it definitely does reduce the morbidity in this setting. So they are great medications, even in heart failure with preserved ejection fraction. Now, MRAs, we have spironolactone and eplerenone, which I talked about. Now we have a new one that's popping up here known as finerenone, which came out in 2021, but there is a new study that just came out of finerenone last month, and it's focused on the use of finerenone in this patient population. So spironolactone had a little, it may help reduce morbidity. And again, that means hospitalization due to heart failures. It may help reduce that. Finerenone in its new study was shown to, for sure, reduce that heart failure hospitalization risk in this patient population. This is hot off the press, this finding, so we're not going to find it in any guidelines right now, but it's very interesting. I think it's very cool. You guys might start hearing about it from your cardiologist soon enough. And a great thing about finerenone, like I was saying, spironolactone can possibly cause gynecomastia. Finerenone doesn't have any of that. So that's a plus, but the downside is it is a newer medication. It is more expensive, but there are coupons out there for its use. Lastly, we have ARBs and possibly Entresto that could be used in this patient population. They may reduce the morbidity aspect in heart failure with preserved ejection fraction, but we don't rank those as meds that we would use over something like an SGLT2 inhibitor in these patients. I know that was a lot of information to go through, but I am more than happy to answer any further questions or go back on any parts of the slides to clarify anything.
So there were a few questions that were put in the chat, and then we'll just kind of open it up and people can just be respectful and raise your hand or whatever. So moving back to ACE inhibitors, if you do have a cough in response to an ACE inhibitor, but it doesn't really bother you that much, can you just stay on the medication?
You can. It's not something where you have to get off the medication. You can see if that cough stays stable, and if it doesn't bother you that much, you can continue it. You just want to keep an eye out. Now, if that cough gets worse and worse, the way that this cough is actually forming, that might give a little bit of a better idea. ACE inhibitors increase a substance known as bradykinin in the system, and bradykinin is what's causing that dry cough, but it's also what's causing that angioedema. So, if your cough is getting worse and worse, then I would say maybe start talking to your doctor. You might want to get switched off of it. But if it's not very bothersome right now, you can continue it, but I would just watch it.
Okay. And then moving back towards, you touched on cholesterol and statins. There's a lot of buzz lately about LP little a, I think is what they're calling it.
Yeah, the
And
lipoprotein A.
what exactly is that? And in the end, do statins help with managing levels of that are not in range?
To be honest, I would actually have to get back to the group about that in regards to statins with the LPAs. Not everybody gets an LPA drawn. There's a lot of buzz about LPAs and apolipoprotein B. And there's specific patients who get either of those drawn. I need to go back and double check the patient population that they do draw those on. But I want to say for the LPA, it might be if you have like a family history of like premature cardiac events, but I'll double check and I'll get back to you, Karen, about that as well.
That'd be great. And then I'll share with the group. Yeah.
Yeah, and I'll let that. But in terms of statins, we're really focusing on the LDL reduction with the use of statins. But I know that they possibly can help with LPAs. I just don't want to give a blasé answer here, so I'm going to double check myself and then send it to everyone.
A couple more questions and then we can open it up to the group. So I know that some of us are new to sort of a cardiac diagnosis or new to this whole world. And there's some confusion. Why do you have to be on two different types of blood pressure medications like losartan and metoprolol, or why do we have to have both?
So it depends on the cardiac indication and what we're trying to treat. Now, something like metoprolol and for example, losartan, we would see pretty heavy within a heart failure with reduced ejection fraction patient, or a patient who's like post heart attack who also has chronic kidney disease or a heart attack in the anterior wall or something. Um, Using those are beneficial because they both work against cardiac remodeling in different ways. They have different mechanisms. So now we're starting to really support the heart and its strength through different ways to really protect the heart from remodeling. And so most of the studies have shown that if patients are started on these medications, especially in the setting of heart failure, like for example, those 4 pillars of medications I was talking about, most of the studies have shown if we start patients on them as soon as we can and start titrating up to target doses that your doctors want you at, the patients have had way better outcomes of staying out of the hospital and a reduction in cardiovascular mortality compared to those who've only been on a few and haven't been maximized on the combination therapy. And it's just because they're working through different mechanisms. And so it's really supporting the heart that way.
So it's not unusual to see cardiac patients on 1 or 2 or even 3.
Yeah,
Right?
or even
This is
4.
a bit of a cocktail, right?
Even 4. I mean, I've had patients who haven't had a past medical history of anything. They've come in with a heart attack and they've left on 5 medications, like they're on aspirin and Plavix, and they were on metoprolol. They were a high risk heart attack patient, so we put them on losartan. Then they needed a statin, so that's 5 to 6 medications right there.
Yeah. Let's see. Where do you find the coupons that you reference as you talk about some of these medications?
So I usually, in the hospital setting, for my patients, I actually like to do it for you. So I will go online. There are Googleable actually, and I can actually show everyone if you want me to share my screen. Um,
I think that'd be great.
yeah, so let me,
You can just go to the drug manufacturer's website, potentially. Is that what you're saying?
yeah, you can go to the drug manufacturer's website. So here, let me share. So let's say for Entresto, I want to find that coupon. So I look up Entresto coupon. I just Google it. And then if you see like savings and support, financial support, if you go through, you'll see sign up for a $10 copay card. You can click on that. And then here you can start signing up. That's like one way you can do it. Another way that you can do it is just doing savings and support. And so here you can enroll yourself. And then you'd say, like, I'm enrolling myself. You're 18 years or older. And then here you have to know what prescription coverage insurance you have. If you have Medicare or Medicaid, typically that will limit your use of coupons. If you have commercial insurance, then the coupons all should work for you. But Medicare, Medicaid, TRICARE, DOD, those are limited use on the coupons. And if you're not insured, limited use on the coupons as well. Some of these medications have like a free trial offer for the first 30 days. Other ones don't. So you just kind of have to look at the website to do that. But that's how you can get to the coupons. Another way though is, it can be overwhelming doing all this yourself. Reaching out to your cardiology office to ask for help on that for copays and coupons, I think is very fair. We like to do that in the hospital as much as we can to help out our patients. So I will set up my patients with ticagrelor coupons, Entresto coupons wherever I can, SGLT2 coupons. So if you're
Don't
on
be
my
afraid
unit,
to
I usually
ask,
go.
right?
Yeah,
Don't be
I
afraid to
think
ask the provider. Yeah,
yeah. Don't be afraid to ask a provider and make sure that they're aware.
got it. Thank you. All right. What is it specifically about grapefruit that messes up, the efficacy of some of these meds?
So grapefruit works on, so we have this enzyme in our liver known as CYP3A4, and CYP3A4 is responsible for breaking down statins, and it's also responsible for breaking down ranolazine. What grapefruit does, it actually inhibits CYP3A4. So if it starts sitting there and inhibiting CYP3A4, the statin molecule, the ranolazine molecule, can't go there to be metabolized and clear out of the system. So then those levels just keeps building up because it can't get to the enzyme to be broken down.
And that's true for grapefruit juice and grapefruit, the actual fruit, both.
Yeah, we say just all-encompassing grapefruit and grapefruit juice. Now I know that sometimes there is and I think a dietitian would probably be better at kind of getting to the nitty-gritty of it, but there are thoughts that it's really about the amount of grapefruit you're having that could really be setting this off. Like it actually takes a lot to possibly do this. But for safety of our patients, we like to just say that if you can stay away from grapefruit, please do it.
Got it. All right, and let's see. Is there a hormonal effect of spironolactone or Jardiance? Is that related to how they work? Did you understand the word I stumbled over?
Yeah, yeah, it's spironolactone.
Thank you.
So there's not much of a hormonal effect really with Jardiance, but there is with spironolactone. So that's a great question. So, like I said, spironolactone is what we call a mineralocorticoid receptor antagonist. And so aldosterone works. It's a hormone basically. So it blocks the mineralocorticoid receptor, and then we see benefits in our heart and our kidneys. Now, spironolactone is not very selective for that receptor. It also likes to jump onto other receptors. So it likes to jump on our like basically our testosterone receptors, and it turns it like down. So then that's why you start getting the gynecomastia forming in like the male breast tissue because it starts down regulating the testosterone effects.
Okay, and then somebody also suggests, circling back to the coupon question, talk to your pharmacist as well. I
Oh
think
yeah, so that's Belinda. She's my boss.
uh,
So yeah, we do recommend to talk to your retail pharmacist as well. They're very well versed in coupons. If they call you and they're like, "Hey, your Jardiance is $500," you know, question it, especially if you know that you have a commercial insurance, question it and ask if you can get onto a coupon because, if you can get onto a coupon, why not use it? They're great medications that if you don't have to break the bank to use them, then that maximizes your benefit.
and I don't know if you know this, but is that like a discussion that you have to have every month as you get the refill, or once you're in a coupon program, is it for the duration of your prescription?
It depends on the coupon. So some of
Uh,
these medications, an example like Entresto, they have a 30-day free trial offer. And that is irrespective of what your insurance coverage is. You could be non-insured, you could have Medicare or Medicaid, you could have commercial, but that is only a one-time thing. That is the first time you ever use Entresto. That's the only time it'll work. If you have commercial insurance, then you can sign up for the $10 copay card. If you're able to sign up for that $10 copay card, that's recurring. That'll just keep recurring on its own. You don't have to keep calling the pharmacy to reapply it.
okay, got it. Um, do pomegranates interact with any of these medications?
That's a
Much
great
like
question.
similar to grapefruit.
To my knowledge, I want to say no, but I haven't looked into pomegranate use in this, so I will double check myself, but I want to say no. We don't really worry about pomegranates in regards to this.
So those are all the questions I have in the chat. If anybody else has any questions, you can take yourself off mute if you'd like.
I have a question. It's I'm the person who asked about the spironolactone.
Mhm.
Could it cause hot flashes?
Um, Usually it's working down a testosterone pathway where it's like reducing the effects of testosterone. So hot flashes wouldn't be at the top of my mind for spironolactone, but because it is working through a hormonal pathway, I mean, I would say it's not impossible. It possibly could be a side effect. But I'd be focusing more on it if it reduces your testosterone. But I mean, hot flashes from a hormonal perspective could possibly be a side effect.
Thanks. But Jardiance doesn't have hormonal effects?
No, Jardiance only focuses on having you basically urinate glucose and sodium out. That's all it's really doing.
Yeah. Thank you. Thank you. It's been
Absolutely.
I really appreciate it. It's been interesting talk.
Thank you.
I have a question. Going back with the Jardiance and spironolactone, do they interact adversely with each other?
Not in the sense of like it's not like they're going to stop each other from getting metabolized. Now, keep in mind, if someone has heart failure with reduced ejection fraction, they will likely be on Jardiance and spironolactone. What we need to look out for is just to make sure that the kidney functions are stable and that you're not you're losing adequate volume so that you're not starting to back up on fluid, but you're not losing too much volume and that your labs are stable. So because they can both reduce your sodium, they both can reduce your volume status. That probably could be like more of like a synergistic effect. I will say though, they're not very strong like relievers of fluid from the body. So it's very few and far between that we start telling people you can't be on both. Usually we like to keep patients who need those two to be on those two, but there's no direct like metabolism drug interactions between the two. It'd be more like a synergistic effect in how they work.
Thank you.
Got a question.
Mhm.
Is some of the blood pressure medication be so, I guess everybody's concerned about the top number versus the bottom number, but could the medication drop the bottom number to a dangerously low number, or a low area, or at what point is it a concern?
That's a great question. So it can drop both, really, depending on which medication you're using. Some medications will also drop that bottom number as well. Typically, when it comes to hypertension itself, we just want to make sure your readings, top and bottom, are less than 130 over 80. But if you're starting to see that top number start dropping below 100, that is concerning to us. That means your blood pressure medications are probably too strong. Some doctors might even say less than 110 is when you need to start questioning if that blood pressure medication is too strong.
Okay. Thank you.
Absolutely.
Hi. If you just talked about the blood pressure and the top number dropping below 100, does that, I mean, if it does it occasionally, should I be concerned, or should it be over a period of time?
So if it's happening occasionally, then there's a few questions that raise into my mind. Is it happening when you're changing positions? Is that why your blood pressure is dropping to 90? Or is it after your medications, or what's causing that occasional drop? I would keep note of it. And if you're seeing it happen multiple times, I would definitely bring it up to the provider. Just because we don't want rapid fluctuations in your blood pressure like that, because it can affect other parts in the body. And also we don't want you to fall. So, if you're starting to see that happen multiple times, I think it's best to bring it up with the provider. There could be reasons that are triggering that type of, intermittent drop in your blood pressure.
Thank you.
Mhm.
I found in my research very little on low blood pressure. And I was wondering, I know this was much more focused on high blood pressure, but I was wondering if you could talk a little bit about what you can do naturally, and also what are some drugs out there for low blood pressure, because I've been consistently in the 80s and 90s. It's been erratic within it. I brought it up with my doctor, but I was just wondering if you have other resources I could read, or any recommendations would be appreciated. Thank you.
Sure. So in terms of, and let me just make sure I got this question right. You're talking about like natural ways to lower the blood pressure?
To raise it.
To raise it. Okay.
Right. Because
So,
I've been, since my surgery, I had very normal blood pressure, but since my surgery, it's been never above 100, but without symptoms.
okay. So natural ways, I say this with a lot of caution because it depends on your past medical history. Um, you know, more salt does raise your blood pressure. Now, that's not to say that you should be taking like this like crazy amount of salt in, but more salt can raise your blood pressure. In terms of naturopathic medications and herbs, I can't really speak to those, but in terms of in terms of other things you could do that could raise your blood pressure. And then water intake. Now, in terms of medications that increase your blood pressure, there are a few out on the market, but we only use them if it's appropriate for the patient and their past medical history. A few examples are, and I don't know if you came across these names in your research. One of them is midodrine. Midodrine is a medication. It's typically dosed like 3 times a day. And what it does is it works on the vessels in your body. So if you remember, I was talking about how something like Coreg, which is a beta blocker, also blocked alpha receptors on the vessels. Midodrine kind of does the opposite. It's working on the vessels, but it's like stimulating those receptors so the vessels start to constrict again and becomes like, tighter. So then your blood pressure can start going up. So that is one medication. Another one is known as fludrocortisone. It's a type of steroid. It's called a mineralocorticoid steroid. And what it does is it causes your body to hold on to sodium and fluid in your vessels, so the blood pressure starts going up. So those are some options to bring up your blood pressure, but there could be other questions as to why your blood pressure is persistently low, because there could be other reasons where you might need other medications altogether to bring it up. Like sometimes some patients need steroids because their adrenal glands are stressed out. So I think it's important to figure out like the cause of it, because I think that will drive what you need to be on.
Yes. Okay. Thank you. Yes, I have been increasing salt intake. That was definitely one recommendation. So,
Okay.
yes. Okay. Thank you.
Yeah.
Appreciate
Yeah.
it.
No problem.
Rohini, I have a couple more that came in. One is circling back to grapefruit.
Okay.
What is it about grapefruit compared to other citrus, tangerines, oranges? Like, what is it about grapefruit that, we have to be careful with?
I think it's just that CYP3A4 inhibition on the enzyme in our liver. The other citrus haven't been shown to really do that, or even do that to a degree that would affect your medication's metabolism. But grapefruit does do that. And so that's the main difference.
Okay, thank you. And then another one, I just started at torvastatin 2 weeks ago. I started having leg cramps this week. Does the muscle cramps from this medication normally start this quickly?
Some patients can have them within days to weeks of starting the medication, so that is not uncommon. Again, these leg cramps could be self-limiting. I would say call your doctor, just let them know that you're having the leg cramps. Again, like I said in my presentation, it is self-limiting. Usually what they'll do is they'll probably either reduce the dose of your statin right away and have you continue it, or they'll have you hold the statin and then restart it maybe at a lower dose or try another statin. But for the most part, after this initial phase, most patients are able to tolerate it pretty well.
Got it. Anybody else have any further questions?
I have a question.
Go ahead,
It
Carol.
was an excellent program. Thank you very much.
Thank you.
Where and when can we watch this again?
So as we mentioned at the start, it's being recorded. It does take a couple weeks to get the editing down the way we like it. And then it's put on our YouTube channel, if you will, that we have. It's called Amended Hearts DC, and I'm happy to send that link to you. And I'll post it when it's ready, so everyone will know.
I have some friends who would find this absolutely amazing. So thank you.
No, please share it. Please, you're welcome to share it. That would be great. Any other questions before we close out?
Got a quick comment
Go ahead, Brian.
on the coupons. A lot of times, if you get in contact with the manufacturer, with a lot of folks being on Medicare, Medicaid, they actually are involved in certain grant programs that they can direct you to possibly help you pay for some of your prescriptions.
Mm-hmm.
So you may want to give the manufacturer a call, if you don't necessarily qualify for the regular coupon.
Yeah,
There's also several prescriptions. I just went through the Medicare thing. place. There's several programs, and CDAP is one that, while you may have a low income and have assets, which many senior people have, that can help you with your drug costs.
Good to know. Thank you. Anybody else? Well, I think that's it. So thank you, everyone.
Thank you so much. I appreciate it.